Mm. If I answer this question with evidence-based medicine, I can't confirm that there is a value. But in fact, it is the same value as a clinical examination. And there is no evidence-based medicine also showing the value of asking some questions, some simple questions to a patient. The download of ventilator signals is really like a nocturnal examination of your patient. It is the only treatment in the world for which, that allows you to see what the patient is doing with the treatment. For example, you are going to be able to see, firstly, if your patient takes the treatment, the compliance. Secondly, does the patient use the device for long enough? Thirdly, does the treatment go in the patient, avoiding intentional leaks or upper-way obstruction? And fourthly, does the treatment suit to your patient? Is there any asynchrony? And also, if your treatment is efficient with PTCO2 and oximetry. So for me, true, there is no clinical scientific evidence I can answer after years using it that download of a ventilator signal is crucial in our team, really, and really the future of the modern medicine. The possibility to target a treatment to the needs of the patient, that's the future for me. So the answer, sorry for this long answer, but is clearly yes for us and for my team. In the daily follow-up, the majority of the problems are found and corrected with simple information of the download ventilator signals: poor compliance, leaks, obstructions, and low tidal volume. But I would say in my experience that around 10% of the patients, in 10% of patients, we have asynchrony. And that needs information about what the patient is doing. Belts are the solution for that. But belts, uh, it means a complete polygraphy, it means hospitalization, and hospitalizations means a delay in the polygraphy, and most of the time we can't do it. So we see our patient, and so most of the time we try solution with only hypothesis. Thanks to this incredible idea to switch on two belts on the ventilator, we can have quickly, easily, even at home or in the ward or even in an emergency room, a complete polygraphy. So you can imagine by yourself how useful this tool to decrease the cost of work and the interest of your test can be to have belts to a complete follow-up of patients with mechanical ventilation at home. So for me, big interest and very easy to use, the future. Again, we don't have any evidence-based medicine yet. I say yet, and but in intensive care, they have spent years to show that asynchrony is important and have some clinical issues. With home ventilation, we have only two retrospective studies of our team showing that bad ventilation means bad survival. It was with ALS patients. But we launched last year a randomized control study in COPD patients called Rescue 2 Monitor Study, and it's about that. For the moment, for our team in Paris, it's obvious that it's important to correct asynchrony, and we try to do each time we see our patients. But okay, I can understand that some people need some evidence, but don't forget that the first step, and I'm sure that everybody agree with that, the first step is to check how your patient is clinically. And even me and my team, if we see that the patient is perfectly well, that the hypoventilation is corrected, we don't care about some asynchronies, some leaks, some obstructions, no problem. But ask to your patient, how is it? And if he says, no, I'm not well with this ventilation, or if you find that hypoventilation is not well corrected, and of course, if you see asynchrony in your downloads with belts or even with the traces of flow and pressure, well, for me, it's obvious that that's a problem and you must correct it. So it's obvious, no, that if you see asynchrony, you must correct it. So try to look at it and correct it if needed. Well, the answer is in your question, in fact. To be able to do it at home or in a pneumology ward, or it means outside a sleep lab. You can do it everywhere if you have it on with simple beds with your ventilators. Just incredible. Even in my center, I am head of the rehab center, and we are able to do complete polygraphy with NIV with our patients. Thanks to that. That's cost saving everywhere is the future. The only thing missing now, I think, and is the same thing in my team also, and even with myself, is the knowledge of all the pneumologists reading polygraphy with mechanical ventilation. It's difficult. It's not so easy. That's why we have a European group called Somno NIV, and we are very proud now to have 4 publications in Thorax Journal about this topic in the last 3 years. So use it. It will help you really.